Bismillahirrahmanirrahim. Assalamu alaikum dear student. Welcome to your channel The Anatomy Canvas. In today's class of embryology of the GIT, we are going to discuss with development of the hindgut. So today's learning objective are to discuss about derivatives of the hindgut, to describe development of cloaca and anal canal, and discuss its clinical correlates. So hindgut derivatives are left 1/3 to 1/2 of the transverse colon, the descending colon, sigmoid colon, rectum, superior part of the anal canal, and epithelium of the urinary bladder, and most of the urethra. Some important point to discuss and understand in today's class are that the blood supply, the nerve supply, and lymphatic drainage to hindgut. So hindgut is supplied by the inferior mesenteric artery, mainly supplying the colon, and also the superior rectal artery, which is a branch of the inferior mesenteric artery supplying the upper part of the anal canal. Then the inferior mesenteric lymph nodes are the drainage area for these hindgut derivatives, and autonomic nervous system is the nervous system that is going to supply the hindgut. So very important, you must remember the blood supply as well as the lymphatic drainage, because these two are very important from pathological point of view. Whenever there is a cancer, whenever there is a disease, we have to study the metastasis of the different malignancies. In such conditions, we must know where the area will drain. So upper part that is the hindgut drains into the inferior mesenteric lymph nodes, and blood supply to this area is the inferior mesenteric artery. Little bit revision from the previous class. You may remember that this is the ascending colon, the transverse colon, the descending colon, sigmoid colon, and rectum, and these are the loops of the small intestine. Here is the greater omentum, and behind the transverse colon, the duodenum is passing. So from the distal to 1/3 to half, and the remaining part of the descending colon, the sigmoid, and the rectum, and the upper part of anal canal are all derived from the hindgut. So a little bit about its mesentery. Again, a little bit revision from the previous class. You know that both ascending colon and the transverse colon are pressed against the posterior abdominal wall, where their mesocolon is diffuses and it disappears, and both of these parts, the ascending as well as the descending colon, become retroperitoneal in position, while transverse colon throughout its length is intraperitoneal. Similarly, the sigmoid colon is also intraperitoneal, and this is the mesentery of the sigmoid colon and also the rectum. So these are the different parts which are derived from the hindgut and their mesenteries. When the hindgut develops from the this is the area of the hindgut, and this is the allantois, and this is the area of the cloaca. So a urorectal septum is a mesodermal ridge which appears between the allantois and the area of the hindgut, and it goes distally to the area where the ectodermal pit is present. So this is the area where ectodermal pit is present. This pit ruptures, and here when urorectal septum comes into contact, the inner side is lined by the endoderm, and the outer side is lined by the ectoderm. So cloaca, what is the cloaca? Basically is an endodermal lined pouch in contact with the surface ectoderm at the cloacal membrane, and allantois is received at ventral aspect of the cloaca. Here you can see in this diagram, you can also see this part of the hindgut disappears. This dashed line shows you that this part disappears, and this area of the cloaca comes into contact with the proctodium. So initially there is a membrane, and this membrane diffuses, this membrane disappears because of the apoptotic cell death, but later on There is epithelial proliferation in this area, which will again occlude the lumen, and when these epithelial plug will disappear, a connection will be formed between the cloaca and the outer side. So this area is the urorectal septum. Again you can see this urorectal septum is the mesodermal area which appears between the allantois and the area of the hindgut, and it divides the cloaca into three parts. First part is the rectum, the second part is the cranial part of the anal canal, and third is the urogenital sinus. So in this diagram you can see this area is the cranial part of anal canal, this is the rectum, and this area is the urogenital sinus. So when the urorectal septum comes in contact with the anal pit and the proctodium, there are the separate opening both for the urogenital sinus as well as with the anal canal. The area between these two is present as perineal body. It separates these two openings. So this is the urorectal septum, and these are the openings of the urogenital sinus and the hindgut, and this area is the proctodium. So during 7th week of development, the cloacal membrane disappears. This is the cloacal membrane which disappears, exposing ventral urogenital sinus opening and dorsal anal opening. So these are the two openings you can see in this diagram. This is the ventral opening which is that of urogenital sinus, and this is the dorsal opening which is that of the anal canal. Tip of the urorectal septum separating the two openings forms a perineal body. So in this diagram also you can see the tip of the urorectal septum which is present in between these two areas is the perineal body. Urorectal septum grows towards cloacal membrane, but it does not fuses with it. It is derived from the mesoderm at the junction between the allantois and the hindgut. Again you can see these are the cross sections showing you the direction of the growth of the urorectal septum, which grows to separate these two parts of the cloaca into urogenital sinus and the hindgut. So now we will discuss the development of the anal canal. Anal canal is derived from the two sources, that is the superior third is formed from the hindgut and inferior 1/3 is formed from the anal pit or the proctodium. So the junction of the superior part, that is the endodermal lined area, and inferior part, that is ectodermal lined area, is roughly indicated by the pectinate line which is present over here just at the lower limit of the anal valve. So this area shows the junction of the upper part and the lower part, the upper derived from the hindgut and lower derived from the proctodium. Also 2 centimeter at 2 centimeter distance from the anus there is a cutaneous junction called the anocutaneous junction, which is shown as the white line, and it is the point where the simple columnar epithelium of upper part changes into stratified squamous non-keratinized epithelium over here, and then at the area of the anus it becomes the stratified squamous keratinized epithelium. So you should also remember, very important, that as upper part is derived from the hindgut, so blood supply to the upper part is the superior rectal artery, which is the branch of the inferior mesenteric artery. Similarly, the venous drainage is through superior rectal vein. As compared to this, the inferior part is supplied by the inferior rectal artery, which is a branch of the internal pudendal artery, and similarly this area drains into inferior rectal vein. Also the upper part is drained, the lymphatic drainage of upper part is the inferior mesenteric lymph node, while that of the lower part are the inferior rectal nerve. The upper part, the lymphatic drainage of upper part is the inferior mesenteric lymph nodes, and from the lower part these go to the superficial inguinal lymph node. Similarly, as upper part is derived from the hindgut, so it is not sensitive to pain, touch, temperature, etc. While lower part, as it is derived from the ectoderm, so it is sensitive to pain, touch and temperature, and it is supplied by the inferior rectal nerve. So the this description is very important, not only because because of the point that the malignancies which occur from the upper point, all the pathologies which are present in upper part of the upper 2/3 of the anal canal are painless, while the pathologies which are present in lower third are very painful. Again, from the malignant point of view, malignancies from upper part drain into inferior mesenteric, and while those of the malignancies from the lower part they drains into the superficial inguinal lymph node. Also remember, the malignancies in the upper part are from the simple columnar epithelium, and malignancies in the lower part are from the stratified squamous non-keratinized epithelium. So these all points which I am telling you over here are all MCQs, so you must remember these all points: the derivative of the anal canal, their junction, their blood supply, their nerve supply, and their lymphatic drainage. So you must remember these points. So now we move on to the clinical correlates. The congenital aganglionic megacolon, also called the Hirschsprung's disease. So in Hirschsprung's disease, there is absence of the autonomic ganglionic cells in the wall of the large intestine, and because of this, it cannot respond to autonomic stimulus. So when there are the fecal contents which are present in upper part, the part which is proximal to affected area is dilated. It forms the megacolon, and there usually 33% patient present with the intestinal obstruction in such cases. So this is the radiogram which is showing you the area where the aganglionic colon is present, and this is the megacolon, which is the proximal part. Another anomaly is imperforate anus, in which there is no opening for the anal canal. This is the radiographic study. Here you can see this is the probe with the radiographic material in it, and showing it doesn't enter into the upper part of the anal canal. There is the obstruction over here, and this area shows distended part of the upper part of the anal canal. So imperforate anus is another anomaly. In this diagram, you can understand different variants of the anomalies which are present because of the anomalies in the proctodium. So in this diagram, you can see this is the persistent cloaca, and because of the persistent cloaca, all the area, that is the genital area in the females, in the opening of the vagina, the opening of the urethra, and that is the opening of the rectum and anal canal, they all open into the same area. In this case, you can see there is the anal stenosis, and anal this is the obstruction over here. In this condition, you can see persistent anal membrane is present, and as a result there is the stenosis. In this condition, there is a deviation of the cloaca, and there is the fistula usually present in, and anal pit is present at such its place, and the opening is in the perianal area. In this area, in this diagram, you can see all the three areas, that is the ureter and the urinary bladder and urethra, and the female genital system and the rectum and anal canal, all open separately. In this diagram, you can see there is the rectovaginal fistula. Anal pit is present over here, but there is a deviation of the urorectal septum, as a result of which the last part of the hindgut do not comes into closer contact to the anal pit, and there is no direct communication. So this opens into the vaginal area, and there is the rectovaginal fistula, or there may be the rectourethral fistula as well, as in cases of the males. So in this case, the opening of the rectum is into the urethra. Here in this diagram, you can see anal canal is present, but the rectal area, there is the atresia of the rectal area, and it ends as a blind ending pouch. And in this diagram, you can see this is the proximal rectum, this is the distal rectum, and because of some accident, vascular accident, this area is damaged, so there is no connection between the two. So these are the different anomalies which are related to the urorectal septum and its opening of the cloaca to the outer side, leading to either rectovaginal fistula or rectocloacal fistula, or sometimes persistent cloaca, and all other types of the anomalies. So here I complete my today's class, and the references for the today's class are the Langman's Medical Embryology, The Developing Human by Keith L. Moore, and Gray's Anatomy. Thank you very much, dear students, for your attention for the today's class. And here I also complete the in development of the gastrointestinal system. Inshallah, we will start the next system very soon. Till then, Allah Hafiz.